Good evening, everyone. Once again, thank you for joining our webinar today. In conjunction with Orthopedic Research UK and the FRCS Mentor Group, we're going to have a talk today on elbow trauma, and we're delighted to have Lee Van Rensburg with us. He's a consultant orthopedic surgeon from Addenbrooke's Hospital, Cambridge, who has a special interest in and particularly problems of the shoulder and elbow. So he'll give us a talk about elbow trauma with regards to the triads and beyond. We'll have some short questions, so please write those questions down in the chat box, and Imogen and the other members of the OR UK team will be able to pick those up, as will we, and we'll put those across to Mr. Van Rensburg. We'll then go through maybe some case discussions with regards to the FRCS exam, and we will finish off with some Viva practice. So if you wish to take part in the Viva, please let us know through the chat box again, and we'll make note of the names. I appreciate it's difficult, but it will be a first come, first served basis, okay? And then we'll finish at 9:30, hopefully, and wish you all the best, okay? So I'll hand you over across to Mr. Van Rensburg.
Great, thank you. Okay, so today I'm going to be talking a bit about elbow instability, and Beyond the Triads is the title. So here we have a 54-year-old male who gets involved in an accident. He falls off his bicycle and sustains this injury. I don't know if you can put the first poll up, perhaps, Ruth. So there are your options for polling. Are you going to just reduce the elbow? Are you going to fix the radial head with a plate? Are you going to fix it with a tripod and screws? Are you going to do a radial head replacement? Or are you going to just excise the radial head because it's too comminuted to fix? At the moment, radial head replacement is winning. Man, no one wants to fix it yet. Okay, I think I'll stop the polling there. We're about 3/4 of the way through the people. And there we go. So 7%, 7 of 7, will just reduce the elbow. 20% will fix the radial head with a plate. 18% will fix the radial head with the tripod screws. On the OR UK website, I debated with Roger Van Rit whether to use screws or tripods, and on that plates or tripods, and on that occasion he won. Obviously, his teaching didn't last, and I'll remind him of that when I see him next time. 51% are going to fix that, are going to replace that radial head, and 5% are going to excise the radial head. Okay. Just move to the next slide. So this same case, based on what you're going to do, are you going to take a Boyd approach between ulna and anconius? Are you going to do a Kocher between anconius and ECU? Are you going to do a Kaplan, ERCB and EDC? Are you going to do the EDC split or the Wrightington approach? So we're getting up to about 100 people who've polled or voted there, so reasonable numbers. 10% are going to go through Boyd's interval, that's between ulna and anconius. 40% are going to do a B, the Kocher. 30% are going to do a Kaplan, and 12% are going to do an EDC split, and only 6% are going to do the Wrightington. The Wrightington is an osteotomy. And I think that probably fits, that's stayed fairly steady over my time. I seem to see that people in Europe, or certainly in the UK, tend to prefer Kocher. I guess they think it's safer. Downside with Kocher is you don't get to see a lot. When I go to Europe and possibly to see people talking from America, they're more talking about the Kaplan. If I had to pick that anti approach, I'd do the EDC split because I can never find that interval between ERCB and EDC. Interesting. Funny how we don't all do the same things. Okay. Going to stop the polling there and just do a little bit of talking. So we're talking about instability today, and we're coming down the tree from simple instability to complex. And within complex instability, you've got the severe soft tissue injuries. You've got the terrible triad, which is a dislocation, radial head fracture and coronoid fracture, posterior medial rotatory instability, or that anterior medial coronoid, and then the proximal ulnar fracture dislocations, which include the transolecranon fracture dislocations and the Monteggia variants. And what I'm going to be talking about mostly today is these terrible triads, the kind of instability that often comes with posterolateral rotatory instability, but not unique to that. Many people have written about it, lots of different texts, but this was probably the first text that sort of highlighted to us of how bad it can be. I'll just clear those annotations. 2002, Ring and Jupiter found 11 cases over 7 years. And this pattern of injury is so troublesome and unpredictable that the surgeon should be prepared intraoperatively for persistent elbow instability in spite of repairing the coronoid, the radial head, lateral collateral ligament complex. And they went on to say that even if you repair the MCL, it then doesn't add a lot of stability, and you might need to transfix the ulnar humeral joint, or you might need to do an external fixator. So that's what we thought in 2002. So here we see a 47-year-old lady who has a posterolateral dislocation. There's a radial head fracture and a tiny little piece off the coronoid. Those are initial post-reduction films with a concentric reduction, small little coronoid, reasonable side radial head fracture. Day 2, she gets re-x-rayed and you can see that it's re-dislocated. So what do you do when it dislocates? You put it back in again. She gets manipulated on day 5 and re-reduced. And you can see on the back slab image, the one on your far right, the drop sign, the increased distance between the humerus and the ulna. And as you suspected, day 14, she falls out again. Day 16, she gets a radial head replacement. And that's all that's really in op notes. No mention of the coronoid, no mention of the anterior capsule, no mention of the lateral collateral ligament. And after the radial head replacement gets done, she gets put back into a back slab. You guessed it. Unfortunately, now they left it 6 weeks before they took another x-ray, and that's her x-ray at 6 weeks. They changed the cast for a slightly better cast, a lightweight soft cast. And again, you see that the radial head is dislocated. And that's why the terrible triad has got such a bad name and why it's so terrible. Because if you don't treat it properly from the start, then you will need to put an external fixator onto it. I'm not sure who's doing the drawings. Now, this is not a drop sign, by the way. This is ulnar humeral distraction because you've got stiffness and instability, which is one of the worst situations you can be in. That's the DJD2. This is her now at 14 weeks with the X-fix removed, and she's got an arc of movement from 110 to 45. Not a bad looking x-ray at 6 months, but when you take it out to 8 months, you'll see that there's absolutely no cartilage left in that ulnar humeral joint. And that's a shocking outcome. And that's why the terrible triad is terrible. These are the pictures that Ring and Jupiter showed us in their paper of 2002 with transfixation of the ulnar humeral joint. Radial head replacements with lots of heterotopic ossification. They only found 11 cases. All of them were initially reduced. And out of those that were initially reduced, 7 redislocated. So those 5 that were just going to simply reduce the elbow and leave it at that, not do anything to the radial head, there's a 70% chance you're going to redislocate. 10 out of them had surgery, those 7 that dislocated, and 3 others. And in fact, those that had surgery, 5 dislocated in their post-operative splint. More importantly, those that had a radial head excision, all redislocated. So one of the things you can't do in complex instability, one of the things you can't do as an absolute, there's very few times I'll say there's absolute things, but one of the things you can't do in terrible triad is excise the radial head. The other things are up for debate. Now, Ring and Jupiter said at the end of their paper, in the treatment of this troublesome pattern of injuries, the primary goal should be restoration of elbow stability. And they even went as far as transfixing the ulnar humeral joint or putting on external fixators. This is where it's important, where you need to buy into this concept of static incongruity and dynamic congruity. This idea that if you immobilize an elbow, if you put a back slab or cast onto an unstable elbow, it does not make that elbow more stable. All that were put into a splint, just of the 7 redislocated. Of those that were operated on, 5 dislocated in the splint. And these were the pictures that we've seen earlier of the lady who spent 4 or 5 times going back to theatre to try and get a good elbow. And you see the back slab. The back slab doesn't keep the elbow in. All the back slab does is add weight to the elbow, increasing the drop sign. Now, I disagree with this article that came out in 2005 that if you see a drop sign, that you need to put an external fixator on it. If you see a drop sign, you need to worry about that elbow. But more importantly, you need to get that elbow moving. You need to believe in dynamic congruity. Adding a cast to an unstable elbow merely increases the distraction of your ulnar humeral joint. Adding a splint. Now, I do sometimes use hinged elbow braces. It only adds about 2 millimeters, if you can see here, on distraction. So I don't use them often, but I do use them sometimes. Sometimes the patient needs them. Sometimes their psych needs them. Sometimes I need them. So I don't normally immobilize people, but sometimes I will use a hinged elbow brace if I want to limit their extension a little. You genuinely need to buy into this concept of dynamic congruity. This is a paper by Duckworth. I love what he writes. This is 2008. And he showed us these x-rays of a 24-year-old post-reduction with laxity, a drop sign on the lateral view, and several weeks later with exercises and avoidance of various stress. Various stress puts a collateral ligament stress on your elbow, and they've got a good elbow. When you move an elbow, biceps fires up, reduces your ulnar humeral joint. If you actively supinate your elbow, you fire up biceps. Biceps pulls on bicipital tuberosity, which reduces your radiocapitellar joint. If you pronate your forearm, it doesn't really, I don't believe, tighten up the lateral structures as is often written in textbooks, but what it does is it wraps biceps around the bicipital tuberosity, increasing the tone in biceps, pulling your radiocapitellar joint, reducing your ulnar humeral joint, stopping that distraction of the ulnar humeral joint, allowing the elbow to dislocate. Now, how do you know if an elbow is stable enough to get it moving? Because sometimes, yes, the elbow is so unstable you can't get it moving. And a number of signs have been advocated. Here's the hanging arm sign by this paper by Ruch in 2011. And that's just basically putting the arm out in full extension. And if that arm is stable and doesn't dislocate like that, that's stable enough to get it moving with the provisos of avoidance of various stress. So don't abduct your shoulder, work in straight lines, up and down, lie down in the bed and move your arm up and down. That reduces your radiocapitellar joint, reduces your ulnar humeral joint. Another definition that has often been used is an elbow that is stable and congruent to within the last 30 degrees of extension. Because if your elbow is stable and congruent within the last 30 degrees of extension, it is stable enough to get that elbow moving. It is stable enough to not need an external fixator, not need cross-wired fixation, not normally need an elbow brace. And so this is how I will EUA an elbow. I lie them flat on their back, arm out on the image intensifier, out straight and get an x-ray to make sure that your elbow is reduced. Flex the elbow 30 degrees to disengage the olecranon from the olecranon fossa, and then place a various stress. You can see a little bit of opening on the lateral side, so likely disrupted partly the lateral collateral ligament complex, but the common extensor origin is likely intact in this one. This is a valgus stress test in a normal elbow, and it looks like that elbow is drifting a long way away. And what you need to do is pronate the forearm, lock the radial head onto the capitellum, and also internally rotate the shoulder so that you lock that elbow. And so you'll always find my valgus stress tests are with the arm pronated. And that's how you know it's a valgus test, because the radius will be crossing the ulna. Then that tells me what's happening to the medial structures and the lateral structures, the collateral ligaments and the muscle origins, common extensor and common extensor origins. But I actually don't really worry too much what's happening there. What I want to know is that elbow stable and congruent to within 30 degrees of extension? Because if it is, it's stable enough to get it moving. And elbow instability is treated with movement. So you start with the elbow reduced, fully flexed, and you gradually extend the elbow and screen it. And that's the picture you want to see. An absolutely reduced radiocapitellar joint and an absolutely congruent ulnar humeral joint. If you're really confident, you can go on and take an x-ray with your drop arm sign. I do worry sometimes, particularly in those that I've fixed or spent a lot of time reconstruction. I don't often go to the drop arm I normally stop at about 30 degrees. If it's stable till there, that's it. I stop. I wake the patient up. I've done enough. Then the next step is for me to inspire the confidence in that patient to get that elbow moving. So the treatment of all instability, whether it's simple or complex, is movement. What you need to do is make sure or allow that elbow to be stable enough to move. And often in the second level of complex instability, it means repairing the soft tissues. It means fixing or replacing the broken bones and restoring bony congruity, and then repairing the soft tissues to a degree sufficient enough to allow the elbow to move. And we know it's enough when it's stable and congruent to within 30 degrees of extension. Little bit of screening just to show you what I mean. Valgus stress test. We know that because the radius is crossing the ulna. And on this occasion, he's ruptured his medial collateral ligament and the common flexor origin. You don't open that medial side like that if you've just done the MCL. This is MCL and CFO. And as you go up the ladder of injury from just ligament to ligament and soft tissue, it's more likely to be complex. It's more likely not to be stable to within 30 degrees of extension and more likely to require some form of surgical intervention to stabilize it. There's the varus test, and we see the radial head and neck fracture. We see how the lateral collateral ligament and common extensor origin is gone. There's not much holding this elbow in place. We start on the lateral. Now make sure you bring your eye around to do the lateral. Don't twist the arm, because if you twist the arm, you're applying an external rotation force on that elbow, PLRI, PMRI, but you basically twist the elbow out. So bring your eye around so that you're testing your extension in one plane. And here we see how the elbow goes gradually into extension, and we get to about 70 or 80 degrees and it jumps out. And what does that tell me? It tells me that this elbow isn't stable enough to get moving. And so I need to fix it, whatever needs fixing, till it's stable enough to get moving. And in the terrible triad, we need to think about the radial head, we need to think about the coronoid and the dislocation. And in fact, the dislocation is really thinking about the soft tissue components, MCL, LCL, common extensor origin, common flex origin. And I'll probably start with the most controversial, with the coronoid. So here's an article that came out 2014, terrible triad injuries to the elbow. Does the coronoid always need to be fixed? In 2 years, they found 14. Now Ring and Jupiter in 7 years at a level 1 trauma center took them 7 years to find 11, but that's okay. They found 14 in 2 years. Talking about Reagan-Murray 1 and 2 coronoid fractures, our clinical results challenge the accepted belief that the coronoid must be fixed in all terrible triad injuries, support the notion that the coronoid or anterior capsule repair is not required, and avoidance of this unnecessary surgical fixation in these instances may positively affect functional outcomes. I've highlighted the words that worry me there. Reagan-Murray type 1 and 2. When it comes to the coronoid, we've moved on from Reagan-Murray. No longer this two-dimensional appreciation of the coronoid. There's so much more interesting stuff about the coronoid than just a two-dimensional classification that came out in 1989. In select cases, well, how do you select the cases and how do you know the coronoid didn't need fixing until it's dislocated, or capsule didn't need repairing until it's dislocated on you? And if you've only had 14, I'm sorry, but this suffers from a power problem here. Unnecessary surgical fixation in these may. Okay, well, it may. Lots of things may. 2014. And they show you these pictures of a terrible triad with repair of the lateral collateral ligament and common extensor origin and a radial head replacement that did well. I'm going to take a little bit of a detour now and talk about the classification. Reagan-Murray from 89, O'Driscoll in 2003, and the Adam Watts classification of elbow instability, where he talks about the terrible triad. That would be the combined or the C. That's when it's that little bit of coronoid off and the radial head. And he also highlights to us the importance of this bifacet, this basal one. Now, sometimes it's not right at the base, so it's not quite basal, so it doesn't fit into O'Driscoll's classification of the type 3s. And there's often a little bit of overlap. And sometimes you'll have a bifacet which is hiding or masquerading, for want of a better word, as a tip fracture. Although there isn't really a tip to the coronoid, because there's lots of tips to the coronoid. So none of the classifications are perfect. And I'd certainly move away from Reagan-Murray, because it's no longer just the size of the coronoid, But nowadays, when you're thinking about the coronoid, it's where that coronoid is broken. Now, Driscoll alluded to that in 2003, where he talked about the tip, the anterior medial ridge, and the basal fractures. Adam Watts, in his classification from Wrightington, talking about these combined fractures, which are the true pure terrible triads, where you just need to do the radial head and lateral collateral ligament. But if you've got that bifacet or the bibasal, or it's a little bit more to that coronoid, sometimes you do need to fix that coronoid, yeah? This article came out in 2013 and really shows us beautifully how the coronoid is not this two-dimensional buffer, which we see it as. We see it as this buffer that stops the radial head from jumping up and running forward, that stops the trochlea from jumping up and running forward. It's got the three ridges. And in the terrible triad, the classic pattern is that it breaks off this intermediate ridge, like you see here on this volume rendered 3D CT. This little piece here, that's classic. But sometimes it's a bifacet masquerading as a terrible triad, sort of classic one, and then you need to worry about it. And I think that the coronoid works more than just a buffer, just from stopping the trochlea or coronoid, but because of that little overhang, because of that little hook, it works almost like you see ladies' bags hooks, or you know, a bag hook that's holding on to a table. You don't need a lot of an overhang to really improve the stability to that construct. Now, one of the reasons people don't like fixing the coronoid is depending on your approach, depending on how you try and get to that elbow. Because often if it's breaking off on the lateral side of the coronoid, you can't get to it from the medial side. Unless it's an anteromedial coronoid, you can't get to it from the medial side. So now you're often trying to get to that small coronoid fragment from the lateral side. And really, if you're going with a cocher, the only way you can get to it with a cocher is if you take the radial head out the way. Now there are, and that's why probably 50% of you are excising the radial head, not saying that you can get to the coronoid, but it then provides you access to everything. If you do a Kaplan or an EDC split, you can get to it. But often to get to it, it comes at an expense. And then that expense is that you have to strip the capsule off the proximal humerus. And as far as I'm concerned, when I'm fixing a terrible triad, I want mechanical stability, but I also want to return the proprioception to this elbow. I want this elbow to know that it's developing a drop sign, that it's falling out of the elbow, and that it needs to pull itself up, and it needs to pull itself up with biceps, with brachialis. You can see the coronoid in this corner here through the Boyd's interval. That's the approach I like, but you don't have to do Boyd. But you can see that bit of coronoid. You can move the radial head if it's partially fractured to the side. You can get to that anterior capsule. Now, this was an article that alluded to the fact that suture fixation of that coronoid doesn't restore the kinematics. And it doesn't restore the kinematics because it no longer works as a buffer. It doesn't restore the kinematics because it's probably no longer working as that bag hook I talked about, where just a little bit of an overhang, okay? But I love reading articles, the text, and then looking at the pictures. And when I look at these pictures, I think about this orange structure. And that orange structure there is capsule. And I look at this reflected yellow structure with the blue outline that comes around it. And do you know what that is yet? Yes, that's the anterior insertion of the annular ligament. So now you go cut annular ligament with your Kaplan, with your cocher, with your EDC split, and you break your annular ligament now in two places because often it's ripped off the front part of the olecranon because that's the weak point. We learned about that in 1958. And so for me, repairing these small coronoids, these, I'm going to say it, Reagan-Murray type 1, types 2, I'm going to say tip fractures, but it's, in fact, no. What I'm going to say is these small pieces off the intermediate ridge, because it's that piece of the coronoid that breaks. And I'm not repairing, I used to say I'm repairing the coronoid, but I'm not. What I'm repairing is that anterior capsule, and I'm repairing in confluence the anterior part of the annular ligament. Because I want to bring as much stability back to this elbow as I can so that I don't have to transfix my ulnar-humeral joint, so that I don't have to put an external fixator on this elbow and take out the patient's radial nerve. And I don't want to know that I should have fixed it when I'm all finished and I'm closed. And that's what the problems with those small papers that tell you don't need to fix the coronoid or repair the capsule is they suffer from the fact is that they've only really come across those lowest small lowercase t coronoids. So here's a dichotomy. 2002, we got Ring and Jupiter telling us that despite fixing coronoid, lateral collateral ligament, radial head, and medial MCL doesn't add much, that you're in a world of pain. And here in 2014, and these are not the only authors, there are other authors who are saying the same thing, that you don't need to do the coronoid. Watch out, if you're reading about Reagan Mori 1 and 2, it's a two-dimensional structure. Nah, I want to be talking about someone who's talking about O'Driscoll's classification, or possibly even now the Wrightington classification of fracture dislocations of the elbow. And I think what you'll certainly find if you've come across enough terrible triads is that as there is a spectrum in instability from simple to complex, even within the terrible triads, there's three people who belong to a gang, and there's three notes played on a piano. They're terrible triads with a capital T, and they're terrible triads with a small t. Let's have a look at that. Here we see a 74-year-old female with a dislocation. It's jumped back. It hasn't moved any further laterally or medially. The displacement between the humerus and the ulna are close. And so I can almost predict that the collateral ligaments and the soft tissue injury, the dislocation part to this elbow, is actually relatively small. Small little bit of coronoid. And there's another piece here, but I don't know quite what that is. It turns out that happens to be radial head. And here's a day naught x-rays, post-reduction in a back slab. Now, I don't have a problem immediately putting them into a back slab for a week or so, but I wouldn't leave them much longer than that. And in those post-reduction films, I see no drop sign. So my heart rate is coming down. I'm becoming more, this is a terrible triad with tiny T's. I'm not going to have to worry about this. And if I have a look at the axial scans, they're not great because you can see that the scan was done with the elbow off the side. I see a little chunk of bone. I see another little flake of bone, and I see the radial head coming into view. I'll go and do the coronal fractures, and they haven't quite got the gantry in the right thing. And that's the problem with CTs. Again, that radiographers don't always know to put it into the plane of the humerus or the plane of the forearm. But what you really want it on is the plane of the coronoid. And that's why the volume rendered 3D CTs really make a big difference. I'll just play that coronoid again because I got distracted while I was talking. And there's this piece here. And just the way you've got those hard sclerotic edges, to me, that piece looks like it's a, that piece looks to me like it's a radial head fragment. I just had to move the zoom sort of bits. You might have missed it there on the sagittal, but it looks like there's a small little flake off the top of the radial head. So in this, by definition, yes, a terrible triad, radial head, coronoid, dislocation, but really, not really significant, hasn't displaced far. He has the x-rays in a brace at 1 week. There's the x-rays at 3 weeks, and there's the x-rays at 6 weeks, and there's the x-rays at 3 months. A little bit of HO kicked out in the front, but a pretty good ulnar-humeral joint, pretty good radiocapitellar joint, stable congruent elbow, and a happy patient. So can non-operative treatment work? Yes. Again, Ring from 2010, published in the Journal of Hand Surgery, but it was only a case series of 4. Man, that's pretty good to get a case series of 4 into the Journal of Hand Surgery. 3 did well and 1 was stiff. And they go on to say that in selected cases, you can treat them non-operatively with a small radial head, well-aligned, minimally displaced, no mechanical block. So there's no reason to fix that radial head for whatever good reason. Patients might regain good elbow movement. And I just highlight some of the things. Important thing here are selected cases, well-aligned, small, minimally displaced, might. And so if you're going to treat a terrible triad or complex instability non-operatively, I think it is reasonable, but then you need to keep a close eye on them. You don't then just see them again at 6 weeks because the elbow will slip out without you knowing. She will come back at 6 weeks with a dislocated elbow, and then you're getting into that realm of chronic instability and stiffness, particularly if it's around 3 months. And sometimes you'll see that, which is a bit of a sadness. So yes, you can treat the terrible triad non-operatively with those provisos, but then watch them closely, bring them back early. So here we see a 45-year-old male has an open injury to his elbow. Again, I see a posterior dislocation, hasn't really gone a long way lateral. I see a coronoid fragment. I see the radial head fragment there, and looks like some of the radial head is probably attached to the shaft. hide floating meeting controls. Let's run the sagittals first. So you can see the gas in the soft tissues. I see the radial head fracture. There's a piece off the front, but there's a big piece attached to the shaft. And so although there's two pieces of radial head that are separated from the shaft, there's one big piece, in fact, attached to the shaft. And that's a winner-winner chicken dinner when there's a big piece of radial head attached to the shaft, because then it's quite easy just to bolt those other little small fragments onto it. If the head is totally disassembled from the shaft, and not only are they broken into three big pieces in that dimension, but very thin on the lateral, then I'm thinking maybe I can't fix it. But for me, based on those sagittals, yeah, that radial head is fixable. Okay. 3D, we see it spinning around. And I'm starting to see things here that worry me. And the things that worry me are the ulnar-humeral distraction, the drop sign seen in the CT, which means posterior band of MCL is gone, which means MCL is gone, almost certainly anterior band of MCL. And I'll just spin this one again. And that's not classic intermediate ridge. This is not classic tip. This is the beginning of the bibasal or bifacet. And so is this one of those Wrightington bifacets, which is masquerading as a terrible triad on its own? And that pattern of the radial head, this has more of a buffer. This has been more of a shunt than a rotation to break the coronoid in this pattern and to break the radial head in that pattern. There's also more soft tissue ligamentous mischief happening in this elbow. He gets reduced and comes up, gets seen at a week, and I'm really nervous now. I see the drop sign, but most importantly, I see subluxation of this elbow and how it's point loading. And so there's no way I can treat this one non-operatively, because the trochlear will just erode on this, and within a year, you'll find that this elbow is arthritic. Okay, so this person's having surgery, and here I fixed it with a tripod. And I fixed it with a tripod and the mini screws just to fix one or two pieces back, because most of it was actually intact. And so this tripod is not taking a lot of force. If those pieces were smaller, if I needed more support, if my coronoid was worse, I might have considered plating it. And I've repaired the lateral collateral ligamentous complex and the common extensor origin. There's my varus force, so that looks good. There's my valgus force, suggesting MCL and common flex origin is involved. But I really don't mind whether it's involved or not. What I want to know is this elbow stable to within 30 degrees of extension. And I get to about 45 and it hinges a little, but I get it fully straight and it pops back in again, because I have repaired the capsule. I have repaired the anterior band of that annular ligament, and which, as it goes into further extension, it then pops back in. And so I decided to treat him non-operatively and x-ray him day 4, because I'm a little bit nervous about this one. And I see at about day 4 post-op, again, he's point loading on that tip of coronoid. You can see it. The coronoid is flown away. Now, I didn't fix the coronoid because it was a bit too comminuted for me. But I look at that and I think I can't leave a 45-year-old's elbow subluxed, or otherwise he will wear it out and he will get arthritis. We see that with the anteromedial coronoids. I think that if I flex you, if I start moving you, maybe if you tighten up biceps and brachialis, so I give him a good talking to and say, get your elbow going, get it moving. And we see there the x-rays subluxed at 11 days. And you can't leave that alone. And you can't leave that alone because the trochlear is point loading on that corner of the ulna, and that'll wear away. So relatively tenuous fixation of my radial head, but that's held. The radiocapitellar joint is reduced, but I see this drop sign. And so a few days later, I finish off repairing MCL and fixing the coronoid. Managed to catch it with a screw from back to front. I could have buttress plated it. I had in my mind that I would take off the tip of his olecranon, or in fact excise his radial head if I had to, and use his radial head as an autocoronoid if I needed it. But I managed to get a relatively stable congruent elbow. You see the coronoid still remaining reduced. You see a good ulnar-humeral joint on the AP. So I think we might have got away with it with that one. But watch out though for those bifacet bicoronoid injuries. In terms of the radial head, most people wanted to do a Kocher, some would do a Kaplan. Yeah, I'm not going to go into the approaches today because I don't have all the time. I just need to keep moving. So this was our 54-year-old. Do you fix it? Do you replace it? Do you excise it? There's lots of things that go into that. In general principles, if there are 3 pieces, if you see 3, there'll be 4, and if you see 4, there'll be 5. You can fix it generally if there's 3, and if you do replace it, make sure that you don't overstuff it. Whether you use screws or plate really depends on the other injuries and how much support this lateral structure is going to need, and so I tailor it. Despite what I tried to on the ORUK debate, I do use tripod screws quite often. I use plates if I need to, but increasingly I'm using screws. If you replace it, don't overstuff it. This radial head is overstuffed. It's proud of the lateral facet of the ulnar-humeral joint. This was fixed through a kocher. And so they started fixing a 3-part fracture of the radial head, couldn't fix it. Then they decided to replace it. And by the time they got in there, they'd released the lateral ulnar collateral ligament. Because you're coming through the kocher, you can't see the relationship between your radial head and your lateral facet of coronoid unless you x-ray it. And before you know it, you've overstuffed it. Is this x-ray overstuffed? Yeah, it probably is. Not a lot, but it probably is. I would want that to be just in line here with your lateral facet. Now, you can't take widening of the lateral ulnar-humeral joint. I used to look at this and think that widening of the lateral ulnar-humeral joint was an indication of overstuffing, but that can be very variable, as shown here by Graham King in 2007. And so the real way to tell if your radial head is the right height, the best way is intraoperatively to see it. You can see it from a Kaplan. You can see it from an ED split from the front. You can see it from the back, from the Boyd, but you can't see it from the kocher unless you really have stripped off all of lateral collateral ligament common extensor origin. Sometimes you'll see these x-rays post-op. Is this overstuffed? That is proud of the lateral facet of the ulnar-humeral joint, but there are the x-rays intraoperatively. And the reason that happens is because the x-ray beam they're a little bit stiff when they come for their first x-ray, and so the elbow is partially flexed. And the radiographer, instead of taking an AP radiograph of the forearm, takes an AP radiograph of the elbow in midway between flexion and extension, sort of halfway across. And what you want to do is ask them to take an AP radiograph of the forearm, see an absolutely tangential view of your radial head replacement, and then you can tell whether it's the correct length, because this is the exact same patient. Remember that the radial head moves proximally and distally on pronation and supination. Just for completeness, this anchor is in the wrong place. It should be sitting there. This paper showed us how to take into account the cartilage. And so sometimes your radial head should actually be a millimeter or 2 proud of that corner. But that's probably taking radial head replacement a little bit too far. But it does need to be a little bit proud, just a smidgen. And remember that the capitellum nestles inside your radial head. Don't make it too big, don't overstuff, don't make it too wide, but it also nestles inside the radial head. So your radial head is often a little bit wider than your capitellum. As for rich radial head, there's no right or wrong. This paper suggested that the best radial head is this bipolar cemented Vitalium prosthesis. And the reason it's the best radial head replacement is because once you put that radial head replacement in, no one is going to revise that radial head. You need to come to me saying that you can't walk before I'm going to think about changing that stem. And so people just get into the placement, they get just into Stockholm. Whereas these radial heads, where they work themselves loose, my threshold to replace that, to revise it, or just take it out once everything else is healed, is actually very low. Denise Egendahl did a good study, a review article, looking at all the articles 2016, and said that there's no one that's better than the other, really. That philosophy of the anatomic versus the non-anatomic spacer, I think it's really a 50-50 ball. The proviso being is that the silicon, you can't really use silicon. It doesn't work. Keep away from it. The last thing to talk about is the soft tissue injury to the lateral collateral ligamentous complex. The center of axis runs through on the medial, on the lateral side, and the center of the capitellum, and that's where you want to put your anchor, dead center in the capitellum in essence. If you think of your lateral collateral ligamentous complex as a Y, lateral collateral ligamentous complex proper, then the anterior band, which goes over the top and attaches to that little ridge where your intermediate ridge is, and then onto the supinator crest. Remember, showed you that picture earlier, that type 1 coronoid, the little piece off the intermediate ridge. It's not about that little piece of bone, because you can't biomechanically reconstruct that bag hook, but you can by repairing the anterior capsule and by repairing that part of the annular ligament through transosseous drill holes through your ulna, which you can see if you've removed the radial head, which you can see if you've done a Boyd approach, will bring more stability to the elbow. Now, you won't dislocate if you don't refix it. You'll have laxity. And that's what this article is saying. If you break it in one place, you'll get laxity. If you break it in two places, you'll get instability. If you're doing a Kaplan or an EDC split, you need to make sure that you repair that annular ligament well. For me, the nice thing about Boyd is I can get a really good modified Kessler in my annular ligament with transosseous drill holes through the subcutaneous board of the ulna and get it absolutely rock solid repair. Most times, the annular ligament is a complete avulsion off the common extensor origin with the soft tissues. Sometimes it's shredded in the middle. Occasionally, you'll see it ripping off the supinator crest, but that's like a rarity. And so most times, a single anchor into the common extensor origin, a mass repair of your lateral collateral ligament in common extensor origin, but do be prepared to create an internal brace if they have one of those where you've shredded the MCL in the middle. Normally it's this, and you can fix it fairly easily. In acute repair, you can just put an anchor into the center of the capitellum and repair it all as a mass repair. I use a decent size anchor, so 5.5 twin fix with 2 fiber wire. You really want to be able to have the confidence to inspire your patient to get it moving. You can't be tenuous at that elbow, because if you don't move it, it'll just dislocate again, as Jupiter and Ring showed us. These sort of anchors for me are a little bit too small. That loaded with eighth bond is not going to hold on to anything. If the LCL is shredded mid-substance, then be prepared to create an internal brace. An internal brace is this concept of a high-density polyethylene suture between the insertion and the origin of that ligament. And the insertion and the origin of the lateral ulnar collateral ligament is center of capitellum and the supinator crest. Here you can see an internal brace created on the medial side, but you can create the same on the lateral side. Where do you put your anchor, or where do you put your holes for your internal brace on that supinator crest? The answer came from this study looking at single bundle lateral collateral ligament reconstruction, not internal brace. They looked at a distal hole and a proximal hole, and basically they showed that there's no difference. And so they simply put it in the middle. It's very seldom in acute terrible triads that you need to reconstruct it. You need to reconstruct it if it's been delayed, or if it's redislocated, or it's dislocated 4 or 5 times and been left for 3 months. Most times in the acute setting, you can get away with an acute repair, or an acute repair plus or minus an internal brace. In general, most of the protocols will be to address, although there may be laxity of the MCL, only to repair the MCL if there's absolute instability. If that elbow is no longer stable to within the last 30 degrees of extension, then you need to go around the medial side. And the one we're repairing most often is the anterior band of the medial collateral ligament. A few articles looking at whether it's in tight inflection extension from the late 90s. Slightly better study showing us the 3-dimensional structure of that anterior band of the MCL, suggesting that it winds around and that they all probably are symmetric. But the bottom line is, anatomically, when you're repairing a medial collateral ligament and you don't know where to put your anchors, is that's the spot, not in the trochlea there, but in the anterior inferior medial epicondyle, and then running along that crest of the sublime tubercle. And the time when you're going to be repairing the MCL on the medial side is often when the bomb's gone off there, so the CFO is pulled off, and you just need to feel for those bony prominences, and you can put your anchor in, repair with whatever sutures you got, what little bit of the medial collateral ligament you can find, but then leave one set to tie to each other as an internal brace. So let's have a look at this case. MCL, common flexor origin, lateral collateral ligament, goes into extension unstable. Gets radial head replacement, lateral collateral ligament reconstruction, and you can see the drill holes from front to back here. So I always repair capsule and annular ligament, that little bit of coronoid. I'm not really fixing the coronoid, I'm repairing that capsule. There we see the varus force, there we see the valgus force, opens up, starts off reduced, goes into extension, and starts to hinge out. Now I'm worried a little here that this may not be stable enough to just absolutely get it moving. And so now I need to go around the medial side and repair the medial side. There was quite a significant injury to medial collateral ligament, common flex origin, and he had shredded the MCL. So I've created an internal brace between medial collateral ligament insertion on the anterior inferior medial epicondyle and on the sublime tubercle, anterior medial coronoid. Just showing you again the significance of that medial injury and likely why they required it. And once you've done lateral side and medial side, testing the elbow in extension, elbow is fully congruent in extension. And what does that tell me? That tells me that this elbow is stable enough to get it moving. That tells me that I don't need to transfix this elbow. I don't need to put an X-fix onto this elbow. And in the last 15 or so years, I've never had to transfix an acute terrible triad if I've followed the principles of repairing the various structures and then reassessing it and not stopping until I've got full extension and stable and congruent within the last 30 degrees of extension. Just another case showing you again the internal brace and how that returns stability to the elbow. So in summary, the terrible triad is a complex injury involving the radial head, the coronoid, and the dislocation. And even within the terrible triad, which is within the spectrum of elbow instability and complex instability, there remains a spectrum within the terrible triad. You need to think about your radial head. You can fix it, you can replace it, but you can never excise it. You possibly don't need to repair the coronoid, but those are only in those terrible triads that are small t's. Think about your lateral structures. Start off on the lateral side first, fix that, reassess the elbow, and only go around to the medial side if you have to. When it comes to the coronoid classification and thinking about your coronoid fracture, if you have the luxury, get yourself a volume rendered 3D CT. Look at that coronoid. Is that a true terrible triad coronoid from the intermediate ridge, just a small little piece? Or is this perhaps one of those bifacet, basal fractures that Adam Watts was sort of alerting to us? And those are the ones that maybe you need to buttress it. Maybe you need to reconstruct it, either using tip of olecranon or radial head fragment if you need. Watch out for those bifacets, bifasals. They'll catch you sometimes. Once you've done the lateral side, and for me, I always do the capsule and that suture fixation of coronoid, because I'm going through Boyd, then reassess it. And I'm not worried if there's MCL injury. I'm only worried if it's not stable within 30 degrees of extension. So if this elbow looked nice and congruent at this point, I wouldn't go around and fix that medial side. And I only fix the medial side if I need to. And generally, if you get an acute terrible triad and you deal with everything appropriately right from the start, you don't bury your head in the sand and simply reduce the elbow and hope it'll be okay, the terrible triad often is not so terrible. Any questions?
Hello. Yes, there are a few questions. Thank you for the excellent talk, and that cleared a lot of things in my mind, actually. So which classification do you use for the coronoid fracture? I think there is a bit of, is it to use the O'Driscoll classification or the classical tip less than 50 or more than 50%?
I think, although when I first started 2005, I looked at Sean O'Driscoll's classification. I thought, oh, sir, you've just complicated it too much. But you need to at least go to the level of Sean O'Driscoll. You can't just look at it on a lateral anymore, particularly because it masking inside this whole spectrum of instability is the anteromedial coronoid. And you only pick those up if you look at the three-dimensional structure. I'm just going to move there quickly. So within the spectrum of instability, you've got complex instability. One of them is the PLRI type, the terrible triads. But you've got this posteromedial rotatory instability, which affects the anteromedial coronoid. And if you don't look out for that injury, now if you're a generalist, you probably will only come against one or two in your career. But a year down the line, a relatively innocuous looking injury to the coronoid will end up with quite severe arthritis. And the reason people don't tolerate arthritis of that anteromedial facet is because every time I pick up something, every time I reach for a cup of tea, every time I reach for product placement, Coca-Cola. I know you're not allowed to do product placement. But every time you reach for something, you put a various stress across your elbow and you load it. You offload your radiocapitellar joint. And so you don't tolerate anterior medial coronoid. You can't tolerate a subluxed elbow. And if you miss that bifacet, which is running on that bit of coronoid, not coronoid, on that bit of, the little bit left in the ulna, the coronoid bit that's left, it wears out, start a process which leads to fairly rapid arthritis within the elbow. So I think if classification, if you're treating elbow instability, you need to at least think of O'Driscoll's. I disagree a little with his concept of the tip. His is more to the middle. I like the idea of the intermediate ridge, but that's just because I've got to be different somehow. I like Adam Watts's classification, but too complex for me, but yeah.
Okay, thank you. So another question, how much joint space opening do you consider significant, and do you compare it with the other side?
A good question. So are you talking about joint space opening on your ulnar humeral joint, i.e. your distraction, or are you talking about joint space narrowing on the medial side when you're testing MCL, or lateral side? And the answer for that is I actually don't have an answer. We are hoping we will come to a height of the coronoid, which is significant, which separates it from those little pieces that you don't need to worry about to the bigger pieces that do constitute a convex bifacet. I think I take a lot of things in my head as to deciding when this is stable enough and when I've done enough. But the most important really is that you fix something or do something on the lateral side. It's often easier to start there and then reassess. How congruent is that elbow? For that radial head that had an MCL injury, I then look back at that MCL injury and is that a monstrously big MCL injury? Is it just opening on the medial compartment 4 or 5 millimeters? So i.e. just medial collateral ligament, not medial collateral ligament and common flex origin. But like that one I showed you, it was both. Whereas I can actually make a big difference to that. If I've got 2 or 3 mils of ulnar humeral distraction and my MCL injury isn't that big, it only opens 4 or 5 mils, I'll probably take a run with it and wake you up and just get you moving your elbow.
Thank you. And well, why to check the elbow stability from 0 to 30 degrees if the olecranon is already engaged?
Yes. So yeah, that last 30 probably doesn't make a difference. So once the olecranon engages, in fact, I've seen elbows that jump in the mid zone. Yes, but what I want is an elbow. I've got it reduced at 90. I want it to get out to at least 30, because if it gets to 30 and reduced any further, it normally locks into the olecranon and then stabilizes itself. But I need to get at least 30 to be sure that I can look that patient in the eye and say to them, look, your elbow is stable enough to get it moving. No, I mean it. The elbow is stable enough to get it moving. Yes, I know you've dislocated the elbow, but get it moving.
Thank you. And do we need to always repair the capsule in interval triad?
Well, that's the debate, sir. No, like some of those articles would suggest you don't. But I worry a little about those articles with numbers of 14, that they're not really picking up the really complex terrible triad, the one that has completely ripped his anterior capsule, that anterior band of the MCL. So yes, it's still a little bit open to debate. The wind is swinging to not having to repair that capsule. I repair it because I like the proprioception. And anecdotally, one of my fellows has written a paper, but it hasn't been published yet. I see less of a drop sign when I've suture lassoed that anterior capsule. And in fact, for me, going through Boyd's interval, I don't have to fight to get to it. I don't have to do anything more to get to it. I push the radial head to the side with a laminar spreader or with a ring handle spike, or through if the radial head's not there anymore, put 1 or 2 sutures into the capsule, 2 drill holes from the subcutaneous border of the ulna, retrograde shuttle them, and it's done. It's not a big fight. If you're coming from a lateral approach, if you're coming from a cocker, yes, you can't get to it unless you've taken out that radial head.
Yeah, thank you. And if you have to repair it, will you use sutures or anchors?
So I normally do sutures. By looking down into the wound, I'll put sutures through the capsule, normally a fiber wire suture, and then drill from subcutaneous border of ulna down into the coronoid. I'll just show you a picture.
Yeah.
So this is the area that I'm catching here, really this capsule. And if you take a stab incision over the point of the olecranon and drill with a 2 millimeter drill and exit into the base of where your fracture is, or where your fracture is on the other side, you can then reverse shuttle those sutures. You weave it in here. It's in this article. So there you can see the drill holes and the sutures that have been passed through the subcutaneous board of ulna into capsule, and then pulled on those sutures, reducing the capsule, reducing that little bit of coronoid.
Okay, thank you. And well, the classical question of whether or not to when to fix, replace, or excise the radial head.
I wish I had an absolute number there. It really depends on a number of things. So depends on so it's not just dependent in the terrible triad on the radial head, because I'm also looking at how much support this lateral column is going to have to afford this elbow. So if MCL is intact, for example, the coronoid fracture is just a tiny little piece of the intermediate ridge, it's not masquerading as a bifacet, then that radial head is not going to take a lot of load. So my fixation of that radial head can be tenuous because it'll be locked between capitellum and locked between annular ligament. But if my radial head is if my coronoid is dust or lots of little pieces, I've got a big medial injury to the medial collateral ligament in the common flex origin, then I need a lot more support on the lateral side. If you're in your 60s, 50s, well, I might as well just, I'm 50 now, sir, okay, but I might as well just chop out your radial head and give you a really rock solid lateral side, which will then support my MCL repair, which will then support my coronoid repair. So yeah, when do I fix it? I fix it when I can, because I'm a fixer more than I'm a replacer. And yeah, I'm always prepared if I've fixed it and it just doesn't look right, because sometimes it can be difficult to get it anatomic. Sometimes, you know, particularly if you're using a plate, you can't quite get those 15 degrees right. It's not running true. It doesn't take long to replace a radial head. Take out the saw it off and replace the radial head. If you're in your 20s, 30s, 40s, 30s maybe, I'll work very hard to repair it and keep it for you, because you can reconstruct it on the back table and put it back in and incorporate it. So it's amazing how this fresh osteochondral autograft actually reincorporates.
Yes, thank you. So if there is a patient with a well-reduced elbow and there is an isolated coronoid fracture, do you always do an examination under anesthesia plus minus stabilization afterwards, or you can just treat him conservatively?
Good question. So now what I want to know is, where is that coronoid fractured? So I have a presentation on that, but it might take me a bit too long to get it up. So I'll just talk you through it. Because if it is this intermediate ridge, okay, so it's the beginning of a terrible triad, but there's no radial head fracture. But the elbow, the ulnar humeral joint is absolutely rock solid congruent. You look at the elbow and there's no significant swelling medially laterally. When you look at your first images and you find that the elbow hasn't really moved far apart, and the post-reduction forms are absolutely congruent, no, then I don't think you need to do anything. If I'm worried that it's maybe not that pure classic intermediate ridge, but actually stretching across to the medial side, then I would get a CT. And I want to then see on that CT, in fact, if you've got 30 seconds.
Yeah. Of course, we've got time.
This is the reason why. So here we see a 45-year-old who injures his elbow, feels it pop, comes in with it reduced. And these are the x-rays that you see. And I see here that this worries me. The first picture on the right. Now, you don't see it on the post-reduction film. We just got lucky that we saw it in this plane, but this is involving the coronoid on the medial side. If I look on the lateral, this is a Meyer-McKeever's 1, maybe even 2, okay? Doesn't worry me. The post-reduction film on the humeral joint is congruent, but I get a CT, sorry, the zoom, and I CT him, and I see how this injury is all the way across on the medial side of the coronoid. That without a radial head fracture, which is unusual because it's not a terrible triad. So how does that fit? Okay, now I'm getting worried about this elbow. And in a 45-year-old, for him, I'm worried enough to do an EUA. I see a perfect radial head, not a scratch on that radial head. Conoid's coming into view now. And I see it starting on the medial side, so that's intermediate ridge. But as I come more medially, this conoid fracture just gets bigger and bigger. But it's not point loading on the ulna, so I'm still thinking, this is probably okay. Maybe I can just get this elbow moving. But I'm so scared now of the anteromedial conoid, I take him to theatre. And you can do the EUA without the A's. You can just do the examination under anesthetic. And I do a varus stress, and this is the classic anteromedial conoid. The next one on from the terrible triad is the anteromedial conoid. Go read about it if you don't know it as an isolated entity or injury to the elbow itself. And I see some rupture of the lateral collateral ligament, but most of the force here has been entered into this anteromedial conoid. There is my force, and I see the anteromedial conoid is good. I'll put my valgus force on it, but as soon as I bring him into extension, he subluxes. And so you do need to have a three-dimensional view of where that conoid is broken. And in the end, that's the conoid that needs fixing, or otherwise they will wear out their elbow. And that took an anteromedial plate. Whereas the 16-year-old in the next case has a really tiny little piece of his conoid there. But when I CT him, there's a little crack in his radial head. That's as it started rolling out of the back of the capitellum. So it looks like a PLRI pattern. It looks like a terrible triad pattern, which never quite completed. I see the little piece off the intermediate ridge, but I come across to my anteromedial conoid to the medial side, and that's pristine. This elbow I don't need to worry about. This person doesn't need to go to theatre to have an EUA.
Okay, thank you. What is the sequence of repair or fixation you recommend?
So I would recommend examine the elbow first and decide where the majority of your injury is. Start on the lateral side. Fix or replace your radial head. Prepare your sutures in the anterior capsule, depending on where you are, before you've definitively replaced your radial head, if you're going to do the capsule and the coronoid. Then do your lateral collateral ligament. So essentially, I've done everything on the lateral side. I've done radial head. I do coronoid and capsule because I like capsule and the anterior band of that annular ligament, and the lateral collateral ligament is complex. And then I EUA them. Then I see whether they're stable to within 30 degrees of extension. And if they are, I stop. If they're not, that normally means they've got a medial injury. I go around the medial side and repair the medial side. And if you've done those properly and well, then it's very seldom, or that I've yet found, that I've ever needed to X-fix someone or transfix someone.
And what's the approach for the medial side?
Medial side, so I would normally do my elbows supine, but I do a universal posterior skin incision. So I come down the point of the leconon, just to the lateral part. I fold it back and I go through Boyd's interval. That's between anconius and ulna. Once I've done everything here on the lateral side, if I need to come around the medial side, I just elevate my skin bridge. And then often on these elbows, particularly if they've done CFO, it's like a bomb's gone off, but essentially you're going through Hotchkiss. You're splitting the flexor pronator muscle mass. So I'll find the ulnar nerve, which is sitting just about there, just to keep an eye on it, and then come in front of the ulnar nerve. And often the common flex origin has been shredded off the medial epicondyle, and you just go straight into the elbow. You put one anchor into the anterior inferior medial epicondyle, one anterior into the sublime tubercle or the anterior medial coronoid, tied one set of those together, creating an internal brace on the medial side. Weave the rest of your sutures into whatever rat's tail you can find of the of your medial collateral ligament, and then weave that into your common flex origin, and that's how I'd repair it. But often the dissection's been done for you on the medial side. If you're a classic Kocher Kaplan from one single lateral incision, well, then you just have to make a separate medial incision. Be aware of the medial antebrachial cutaneous nerve because you are coming close in its territory if you haven't lifted your skin flap.
Thank you. And what's the post-op rehab you recommend?
So post-op rehab, no one gets a back slap. Sometimes if I've had a really big medial injury, I'll put them into a hinged elbow brace. But most people will wake up without a back slap, just in a bulky bandage. And they get told active assisted flexion as much as is comfortable for them. Active supination. Because active supination pulls on biceps, pulls on bicipital tuberosity, reduces radiocapitellar joint. Okay. Active and passive pronation, because pronation actively tightens up your radial biceps tendon as it wraps around bicipital tuberosity, okay? And avoidance of varus stress. And basically for the instruction to the physios is to avoid shoulder abduction. So not to put your arm out to the side. I lie them often for their rehab flat on their back and get them to extend against gravity. Because if they're lying on their back, it reduces the ulnar-humeral joint. It detensions the biceps and the triceps, which wants to fight to keep the elbow in joint. And so people will get more movement by rehabbing supine. I do put my hand onto their elbow to show them and to reduce the ulnar-humeral joint, or show them how to do it so that they can hold it in place and then fight against it, push up. Again, the elbow is proprioception poor, and so it needs all the help it can get. So you can give themselves a tubey grip or something, just to give some skin sensation to reassure the elbow that it's not dislocating, so that biceps relaxes or triceps relaxes at the appropriate time. And that's why often rehabbing them supine is better. But what they get told to do, no shoulder abduction. And in those that I'm a little worried about, don't really push those last 30 degrees of extension.
Thank you. And I haven't heard about that, but someone asked about IJS, or internal joint stabilizer.
Yeah, so the internal joint stabilizer from Leader, that is basically an internal external fixator, basically. I think you need that on occasion if you haven't done the other bits properly. Again, Jupiter and Ring in their first article, I think really have scared a lot of people, and rightfully so, because if you don't do a terrible triad properly the first time, it becomes a world of pain. If you're doing an acute injury and you know how to repair the collateral ligaments, and if you can't repair them, then create an internal brace, in the acute setting, I think there's enough intrinsic healing within those collateral ligaments to heal it. If you do get to that situation where you can't repair it, you can't do it, that's when the IGS helps. I've never needed one. I've seen some great results with it. It looks nice, but they put it in and then they don't worry too much about the soft tissue repair. I personally like putting in a few stitches, and I use decent size anchors. I'm not using Ethibond, or small 2.0 vicryl. It's a 2 fiber wire that I'm using to reconstruct my collateral ligaments.
Thank you very much. I think we have to stop questions here and to start the Viva. Thank you very much. There's only one that do you always attempt a reduction fixation of the radial head, even if it's totally knocked out?
If it's very comminuted, then I'll just replace it. If it's a big piece, and there are 3 big pieces in a youngish person, and I'm 50 now, I'd say I'd still try and fix you if I can. I'll still try and fix you, but what I just need is an elbow that's stable enough. So I'll never set out to do a terrible triad unless I had the ability to do a radial head replacement at the same sitting. So I've got the plate, I've got my long extend screws, because if you're trying to do a tripod, you need to have long headless screws. Watch out, normally the standard ones are a little bit too short. I've got my plate, I've got my screws, and I've got a radial head replacement next to me.
Thank you very much. That's the end of the questions. Thank you. Very nice.
Thank you very much, Mr. Van Rensburg.